Good day. My name is Juan Garay. I am the head of the EU cooperation in Cuba. I'm also a professor of global health in different universities. I will try to introduce to you briefly some of the concepts of global health equity metrics, and then reflect upon the ways in which the COVID-19 pandemic may impact global health equity, and the challenges probably they were always there, but it reveals far more clearer how the pandemic should make us all reflect and influence through global health diplomacy into new ways of relating with each other and with nature. Well, the only global health objective which is common to all countries is in the WHO Constitution, Article 1, where all countries commit to strive for best feasible levels of health. The trouble is, those best feasible levels of health were never estimated. We have tried to do so in the last 10 years by identifying countries that have had for the last 60 years sort of comparable statistical records, national statistical records, averages, levels of well-being with the best proxy of life expectancy and healthy life expectancy disaggregated by sex, but with economic means which would be replicable for all people, so feasible for all, that is GDP in constant value, in purchasing power parity, in GNI, GDP, below the world average, and the balance and the equilibrium with planetary boundaries in a sustainable way. We started by looking at CO2 emissions that were compatible with not increasing 1.5 degrees above the pre-industrial levels during this century, and we continue to estimate the ecological footprint of all countries that would be sustainable in terms of the natural recycling of ecological resources. So we identified which countries had a well-being above the average while using economic and ecological means in a sustainable and replicable way. In year 2010, we found 14 countries. In year 2015, we found only 7 countries. And this year, 2021, when we looked at 1960 to 2020 data, we only found 1 country. So it's for you to read and discover. But it is shocking how the number of countries and also the number of regions within countries that have well-being with feasible means and in a sustainable way with nature is going down and down. Second, that makes us reflect on development models, which are probably not the ones that we've been running after, of high-income countries that are unsustainable in ecological terms and unreplicable in economic terms. Second result is that when we compare those best feasible levels of health with the rest, and by adjusted mortality rates, we calculate which is the excess mortality from those levels that could be feasible for all, we can so estimate the burden of health inequity, both in absolute terms, the excess deaths, the deaths which are due to global inequity, unfair deaths, we could say, and second, the proportion of deaths which are in excess of what the world could offer in terms of universal right to health and global health equity. The number of deaths have been, for the last decade, around 16 million, and that represents some 1/3 of all deaths in the world. And this share of deaths, which we call relative burden of health inequity, is higher in women, close to 40%, and slightly lower in men, slightly below 30%. When we look at the age distribution, there's a difference between women and men, and while in both it's high in the under 5 year old groups. It goes down, but it goes down in a slower mode in women, where the main difference with men is in reproductive, in the reproductive age group, and in the post-reproductive age group. So women have an excess burden during those years. The third interesting result is that we have seen that the reference levels of well-being, which are feasible for all, can help us estimate what we call a dignity threshold, below which, in terms of income per capita, no country has been for 60 years able to reach those feasible levels of health for all, which is the way we could measure the universal right to health. And we call that dignity threshold. And the difference between poverty and dignity is really important, and it's important to reflect upon. There are many countries and groups that escape the poverty threshold set by the international community and the World Bank are still far from being able to provide the opportunities to enjoy the universal right to health and those best feasible levels of health for all people. The probably most provocative finding of this analysis is that if you have a dignity threshold, you are able to estimate an excess threshold. The excess threshold is that level of income above which three facts take place. One, well-being does not improve. So even if you have growing levels of income above that threshold, which of course evolves in time, your life expectancy and your well-being is not better than those below that excess threshold necessarily. Second, no country with income above that threshold is able to respect planetary boundaries, so they're undermining the health of future generations. And third, the accumulation of income and economic capacity and power above that level disables many other countries and groups to have enough resources and live above the dignity threshold. So that's why we look at this equity curve as a kind of goal beyond capitalism and communism, a goal for the equitable distribution of resources, which could enable global health equity. Well, how has the global COVID pandemic impacted on global health equity? We've been reflecting on this, particularly in the Sustainable Health Equity Movement, which we launched in July 2020 and now gathers over 200 international networks worldwide and hundreds of health activists and professionals and scientists, and basically, I would say, health right advocates. And it may appear as if those countries that were having the lowest relative burden of health inequity, which were those within the equity curve, and definitely those with GDP above the dignity threshold, were having more total number of COVID deaths per million people. So it may not have further undermined global health inequity between countries. When we look at that burden of health inequity within countries, the story is different, because Gini has increased in many countries badly affected by the COVID pandemic, and there is a very high correlation between Gini and subnational health inequity, burden of health inequity. The other indirect effect is that the global economic crisis that is a consequence of the global shutdown and the many impacts of the COVID pandemic in global economy and trade have hit worse, as it happened in the 2008 crisis, those countries with lower GDP. And the third impact that I would propose for a discussion today is how have we responded globally, jointly, to the pandemic. Mm. And there are many things to say of the way we have not been doing it right. But the one thing I would pick today is how has the world put our collective efforts together to develop global public goods, which is turn global knowledge, research, understanding, and knowledge into global goods. So how that knowledge can reach everyone. We have seen by the development and the access to vaccines that the inequity, in fact, we calculated the Gini index of vaccine coverage, and it was 0.6, while the global Gini economic index between countries is 0.4. So the world is a very unfair place. We're far from the equity curve I was referring to, and the COVID pandemic has shown us that the indirect effects is still to be seen of the economic indirect impact and the collapse of health services in detriment of those socio-economic groups worse off, may be very profound, and the way we have put our efforts together to develop global public goods is far from what humanity needs in global terms and in equity terms. So I think it's time to develop a framework for global public goods and to see how our capacities, research, knowledge, imagination, and solidarity capacities can really counterbalance the prevailing market forces which result in access to global public and sometimes life-saving goods, as it happened with the AIDS pandemic, not just for those who can pay for that, but for all who need them. Thank you so much.